Okay, great. Thank you for coming today, everyone. We have Mr. Sunil Garg with us today, who's actually a very, very experienced orthopedic surgeon. We're really lucky to have him with us today. And I'm just going to hand over to him and he's going to take it from here. So you can start sharing your screen, please, Mr. Garg.
Oh, that's great. Thanks very much, Alka. So, right.
Sorry, I'll just stop sharing mine and then you can.
No, that's fine. That's fine. Okay. Right. And probably be better if I did that. Okay, hi everyone. It's probably 5 o'clock where you are. It's 4 o'clock here. It's a lovely day. So thanks for, I don't know what kind of day you have there. Is it reasonable? Is it sunny or is it dry, muggy? How's it?
It's a really nice day here, actually.
It's a very nice day.
Nice weather.
It's raining in the center, actually.
I'm keeping you guys away from such lovely day then. Okay, so listen, so what, so thanks very much for a kind introduction, Alka. And thank you very much, Alka and Stephen, for asking me to do this talk. I'm just trying to get to the poll and right. Can you all see the poll on your screen?
Yeah, we have to click on it. Yes.
1 second.
Yeah.
Let me see. When I
would you like me to launch it? I can launch it right now.
Can you launch it? Yeah,
okay,
that'll be great.
I've just launched it. Yeah.
Well done. Okay. So guys, just so that I can know you guys better, if you can answer these questions on the poll. So because if you like a lot of Japanese food, then I'll cut my talk to about 20 minutes. If you like Italian and Indian, then we can go on for an hour because then we'll have a bond. So we need 100% votes, guys, because no one knows who you are. So you can just vote. Okay, Indian, Mediterranean. Okay, tough fight, 43% each. 14%, come on. Mediterranean is winning. I'm okay with Mediterranean, to be honest.
Helps you live long.
Yeah, that's the theory, isn't it? That you live longer. But in this day and age, with what we see in the hospitals these days, I don't know if living into your 90s is really a blessing or a curse. I'm not too sure about that. Ah, look at Chinese, only 1% or 5%. No, don't do that. Chinese food is good. No Japanese takers, no continental. You guys are surely foodies. 21 out of 25. Okay, that's very good voting. So I think we'll give it another, shall we give it another 1 minute and share the results so that I can see. People are still voting. Okay, let's share the results now. Let's see. So, right, let's share the results. So 36% Indian food, 5% Chinese, 23 Italian, 36 Mediterranean. Now neck to neck, Indian and Mediterranean. Okay, excellent. Right, next question. If you can scroll down, are you looking forward to working as a doctor? 82% say yes. That's very excited. Oh, that's very good. That's one thing which I wanted to ask you guys. Okay, if you can scroll down so I can see the other questions, please. Whoever is Alka doing it or Stephen?
Can you see it now?
No, I can't.
I think you might have to. Actually,
oh, I see. Oh, I see. Okay, right, fantastic. Have you decided what you would like to do after qualifying? Become a GP, 5%, Join a surgical specialty, 73%. Ah, excellent. 18% medical specialty. Quit medicine. One person wants to quit medicine. Okay. And more about life as a surgeon. Okay. Yeah, I'm happy to do that. How to become a consultant surgeon. And joining one person and nothing better to do. That's why they're joining. Okay, that's fantastic. Okay, we can stop sharing now. That's great. Okay. Very good. Very good. Thank you. Okay, so I'm currently working as an orthopedic surgeon, as a consultant orthopedic surgeon in a district general hospital in the UK. So, right, we can stop the polls. We can take them away from the screen if possible. Yeah. Okay, 1 second. How can I get rid of this? I can't get rid of this. Yeah. Right, so no one is paying me for this talk, sadly. And I have consent from all the patients who have actually been on the videos. So, and the views in this talk are my personal views. Some of them are from universities, companies, etc. So we can discuss that. Right, so you've decided to become a doctor, and that's a fantastic career choice. So this is what I think is going to happen in your next 60 years. You're a medical student now. You'll become some sort of a foundation doctor, you know, when you qualify in some country. Then you will do some sort of specialist training, and then finally you will either become a GP or a consultant if you continue to be, you know, in medicine, and then you finally retire. Okay, yay. So what lies ahead really next 20 years is, so you have, you know, you've crossed the bottleneck of getting into the MBBS course, which is quite competitive wherever you are throughout the world. So you guys are quite intelligent lot, so which is great. But this is just the beginning, sadly. You've got to do a lot of stuff in next few years to get to the consultant level or to the GP, and mainly it is you're going to be in a secure job, which is the best thing, possibly up to your retirement, and you will have nice social status, good money, but you have to understand the demands of the profession very early on so that you can become a good doctor and develop the attributes which are actually needed to become a good doctor. And the most important thing is, in my view, is communication. Knowledge is something which you will gain, but you know, inspiring trust in your team, working in a team as a team member, caring for your patients, that is the most important thing which you need to actually develop as a doctor, apart from the other skills, which is your knowledge and surgical skills or whatever skills you might have to learn as a particular job. Okay. Your personal character is very, very important, pertinent to what and how you will develop on later in life. And you've got to maintain interest, whatever you have. So wherever you work in the world, you're international medical students, you could work anywhere you like, several healthcare systems. Okay, if you come to UK is reasonable. It is you know, ranked amongst the top 20 in the world, and so it's a good system. But most of the systems around have sort of similar training, and so I think this talk will be useful wherever you go. So, and wherever you go, you will see that lots of challenges in healthcare. You got to understand these are really, really important, because people are living longer. They're really living longer. We're looking at average expectancy of life around 90 years in a few years' time. Okay, there's a lot of stress in life, despite having so many things around us, and the public expectations from health are actually, they've gone up. Like, everyone comes after Googling something about their symptoms and about the treatment. And actually, sometimes patients come and tell you that, hey, doc, have you heard about this treatment? I say, oh, I haven't actually. And then you look into it. So, and the expectations are that they will come to the hospital and they'll definitely get better and they'll get the latest treatment. And there's a lot of scrutiny of doctors now. You used to get away being a doctor and a consultant in the old days, but no, not anymore. And for the good, I think, because you know, the public needs to have confidence in doctors, and they trust us. And so we must be you know, a part of the scrutiny process. So we have things like appraisals, yearly appraisals at the hospital, and the GMC does a 5-year revalidation for every doctor. the costs are rising enormously throughout the world. That's a huge challenge to the healthcare, and you will be a part of that challenge, and you can make a lot of difference by reducing cost to your patients. And the remit of this lecture is not that, so we can't cover that. But you have to keep up to the advances in medicine technology, whichever field you are in. So that is a big challenge, all right? So a lot of you have already decided to become surgeons, but this was just is something which I came across. I think most of you must have seen. So if you're a medical student, and if you are not crazy, and if you are hardworking but very mean, you want to become a surgeon. The best one here is, if you are crazy and have no lifespan, no attention span, and then you become an emergency doctor. I found it interesting. So basically, you will end up becoming a foundation year doctor. And what do you do in the foundation year? Okay, so you basically you gain skills and experience. What is that? So you learn how to take history properly, you learn how to examine a patient properly, cannulate a patient, request investigations, which bloods to be done, which x-rays, which MRI scan, which CT scan, interpretation of all these, and going to theater with your bosses, learning how to the anatomical landmarks, opening up the body surfaces, the belly, the chest, the bones, and learning the anatomy and the surgical procedure. Okay, so that's what you gain. But not a lot of this is gained in the foundation year, you might think. As a surgeon, you will actually be working in the wards, mostly 99% of the times. But yes, you can go to the theaters if in your free time and do that. You'll have to do a lot of courses, and I'll come to that in a minute and show you what courses you can do. You have to do audits and quality improvement projects. And if you can publish, that is very good. You have to get involved in leadership, management, and teaching early on in your career, something which is being done in this forum, because you guys have demonstrated good leadership and management and teaching skills because you organized this group, which is a great example of that. Sadly, exams are very important because the public needs confidence in the doctors. And if you have a regulatory body which can say that, okay, doctor and so has passed these exams, which means that they are up to a certain level, they can be given a go-ahead for the next level. So that they're important. Prizes and extra qualifications are also important. Okay, so now at this stage, I want to stop sharing this and show you something else, which is this document. And a lot of my, not this, stop sharing. A lot of my, where is it gone? Okay, wait a minute. Sorry about this, guys. I'm trying to open up something which I can't see. This is a document which a lot of my foundation year doctors have said to me that they wish that they had known about this document. And I want to share this document with you. You might have seen this, and if you have, then my apologies, but can you see this? So this is 2021 core surgical training self-assessment scoring guidance for all the candidates. Basically, when you're in your foundation years, this is what you got to do so that you can apply for a core training position. Okay, so we go and see, first of all, exams. Okay, so in the core training, you have you sat the MRC as part one examination. That's important. Okay, you can see you get 3 marks for that. Okay, attendance in surgical courses, we'll come to that. What sort of surgical courses? Surgical experience, involvement in 15 or cases gives you 3 points. 5 cases, 1 point. Surgical taster week, have you done surgical elective? Sort of courses which you need to do in your foundation year are basic surgical skill, ATLS, surgical skill for surgeons, head and neck courses. Now I'm quite happy to send this document over to Alka or Stephen, and then they can send this to you so that, okay, then postgraduate degrees, if you have a PhD or MD or any other degree, that you get extra marks for that. Okay, and then prize or rewards in medicine, any achievement which you have made, okay, you get part. Any audits you have done. So if you played a leading role in designing and implementation of QI, quality improvement, can you believe this? You get 11 points for that. Okay. or if you've done anything else in the quality improvement audit. This document gives you, if you have taught in the local hospital or regionally for anything, then you get marks for that. Okay. So, and if you are training to become a teacher, like if you have a degree, then it's great. But if you're not, even if you have the local hospital degree of training the teachers sort of thing, then you get extra marks for that. Okay. Then if you do presentations like oral presentation or in a national, international meeting or regional, then you get points like 6, 5, 4, like that. Okay. And then publications, obviously, you get 7 marks for publication. If you're a co-author, you get 6 marks and like that. Okay. If you do leadership and management courses or hold a position, that's how you're scored 8 marks, 8 marks, 6 marks. Okay. And finally, you have the interview. And in the interview, you basically are asked about all these attributes, which you see here, which is about teaching, about experience, and everything else. Okay, so yeah, so this is exactly what you need to do and prepare. So I'll stop sharing that and go back to our. Will that be useful if I send this across, guys?
Yeah, I think that would be really useful.
I've actually just attached the link in the chat so everyone can check the link out in the chat.
Oh, you've done it. You've already done it, have you?
Yes, yes.
Okay, fantastic. Okay. So this is what you do is this is how your years will follow in the surgical training after the foundation year doctor. When you finish being foundation year doctor, core training of 2 years followed by MRCS, and then your specialty training of about 6 years. Then you get the CCT, then you do a fellowship, and then you become a consultant. Okay, so I'm sure you're all very familiar with this path, and this is a UK path. I'm afraid I don't know about other countries, but this is a UK path. Now, this is sadly the competition of getting into core training has slightly sort of it differs every year. But if you can see in 2020, the ratio of application to success was 1:4. Previously, it was 1:2.5. So if if 4 people applied, sort of 1 person got in this year. So 1:4 ratio this year. So, and once you finish your core training, there's lots of stuff you have to do in your core training to get into the SPR job. And it is quite competitive to get into SPR job, especially if you're talking about orthopedics. It is very competitive, but it is achievable. Just like if you can get into core surgical training, you can definitely get into the SPR training. It's just an extension of exactly what you've done as a foundation year doctor and a core training, more like a core training. Okay, the main things are exams and publications. They give you more marks. Okay, and once again, the competitive nature of this position means that you have to fight with other people. So it's roughly about 1:6 in 2020. It used to be in 2017. Can you see from this? It went down to 1:1.8. That was quite worrying, for everyone. But now it's gone back up. So when I was doing this, it was nearly sort of 1:10, and so once again. This is the CCT pathway for trauma and orthopedics, just so that you understand. On an average, you're looking at 20 years. Okay, so I'll quickly run through my journey with you. So I started off in 1990 with my MBBS, okay, and then I became a consultant in 2010. So that was exactly 20 years. So it could be 18 years for you if you're lucky and clever. It could be 17 years, but on an average about 20 years. Okay, so I started off doing my MBBS in Gwalior, that is in central India. Then I did a post-graduation from the same city. Then I moved to New Delhi, to a very big hospital, which was very famous for trauma. I did 3 years of trauma there. And then I came to UK for the training. And then after 10 years of that training, I was able to secure a consultant job. Okay. So this is my college. This is very similar to actually where you guys are. The course which I did was very similar. actually to what you, because I hear from a lot of you that, you know, your course is quite hard, anatomy, physiology, and everything is and surgical specialties. So they ask you quite sort of the passing of the exams is not that easy, and the same was the case with us. But can I tell you that because of that rigorous course training which I had in my MBBS, I found it easier to pass exams when I came over to UK, and that's really good. So these are my two hospitals in Delhi where I worked, and they were good centers. Okay, so yeah, that was a massive jump for me from Central India coming to UK. So when I came to UK, none of my previous experience was counted, so I had to start from scratch, from foundation year doctor sort of thing. And then I ended up working in about sort of 14 different hospitals, and then finally sort of so main hospitals I went to was in London, in Thomas's and Guy's. And then when you are finishing your training, in the last sort of 2 years of your training, you choose a specialty in orthopedics. So in orthopedics, at the moment, you have these sort of 6 specialties. So you can either be a hand and wrist surgeon, foot and ankle surgeon, shoulder and elbow, spine, hip or knee. So I chose to be a shoulder and elbow surgeon. And why I did that, I don't know. But I remember first sort of my initial SPR days, there was a South African surgeon, Keith Borowski, and he was my first trainer. And my first trainer was a shoulder consultant. So when I entered his room, he said, "Okay, Sunil, what's your interest?" I said, "I don't know." He gave me a shoulder book and he said, "Okay, finish that within a week, and I'll see you in theatre." And after that, I just sort of fell in love with shoulders, and then I strategically did a lot of my jobs in upper limb, and thankfully, I managed to get a very good fellowship with this guy. His name is Professor Angus Wallace. He's a Scotsman. So in Nottingham, I spent some time with him learning his skills, and then I was very lucky to get over to Cleveland in USA with just this chap called Joanne Notty, who's a shoulder guru in USA. He's very good in glenoid socket designing, etc. And so, yeah, here I'm in this. This is the Norfolk County. Okay, yeah, we've got about sort of 9 hospitals here, and so the one over here, Great Yarmouth, is where I am currently working. It's called the James Pettit Hospital. So life as a consultant is busy. Okay, you've got a lot of clinical responsibility, no doubt about this. So, but you also have a lot of training and teaching responsibility of juniors, registrars, and at the same time, you have to have a lot of leadership and management responsibilities as well, because you are practically running the hospital and your department. Okay, you get paid about £100,000, okay, on an average, and but sadly, most of that is taken away by the tax. So this is free tax. Okay, but everything depends. Whatever you do in the hospital will be teamwork. So teamwork is the key. So my typical day, you know, would be quite busy unless it's my day off. So I get 1 day off. So I'm off on a Wednesday, and I don't do much in the NHS side of things. On Wednesday, I do private work on Wednesday. The rest of the 4 days. So I have sort of 2 to 3 theatre sessions a week and three clinics a week. So I start my day in the morning at 7 o'clock, and I finish the day at about 6 o'clock in the evening. Okay, so these are my secretaries. They without them, I'm absolutely going to fail in whatever I do. So they keep a good check on my schedule, and they give me the paperwork, and everything is given and sorted out by them. And it's whenever I'm communicating with the patient or the GPs or to my colleagues within the hospital, you know, they keep everything in order. You can't. So what I'll do is I'll just go through a few things which I do, which is, so I love seeing patients in the clinic. So we'll go through some cases if that's okay with you. But at this stage, before I move on to the clinical side of things and explain what I do in the clinics, etc., are there any questions from anyone? Anything on the chat box? I can't see anything.
There's nothing in the chat box, Mr. Garg.
Nothing in the chat box. Any questions, Stephen, Alka?
I think there is one. Someone is just sending it through. If you don't mind starting, I might interrupt you.
Okay, no, that's fine. So yeah, so what I'll do now is I'll show you some videos of patients. So these are typical cases I would see as a shoulder surgeon in my clinic. Okay, so can you hear it? Can you hear?
Just feeling it now. Now, getting worse, getting worse, getting worse. Yeah, that's it. Okay.
So this guy comes to me. He's about 35, 40, okay? And he's got pain in his left shoulder. When he moves it up, he feels the pain
Just feeling it now.
on his left shoulder.
Getting worse, getting worse.
The pain
Getting
is around.
worse.
You can see
Yeah,
the movement of
that's
the
it.
left shoulder is not as good as the right shoulder. Okay, so his pain is coming from that area, and this pain is typical of impingement. Okay, in these cases, what happens is that the rotator cuff. I'm sure what you know what a rotator cuff is. I'll show that to you in a minute. Rotator cuff gets impinged and inflamed, and because of that, they get the pain. Okay, the best treatment initially is just to inject them, and so I use some steroids.
That's the tip, posterolateral corner. That's the tip. 2 centimeters below it, I go in and I'm directing the needle towards the tip of the acromion here. I'm withdrawing and injecting. It goes easily, that means you're right into the bursa. And then you pull out as you inject. Thank you very much.
Okay, press red again.
Yep.
Okay, so, and you will see that they do get better with the injection straight away in the clinic.
Let's do it. After the injection, that feels better?
A lot better, yeah. A lot
Excellent. And turn around, you were going to...
better. Oh yeah. Oh yeah.
Can you
Get up
reach?
that far now. Before I could only go there.
Lovely. Thank you very much.
Yeah.
So it's quite good, these injections. Okay, so I'll do a lot of them, and this is just something to show you what I did and why people get pain in that area. So subacromial bursitis is extremely common, and I see lots of them in every clinic. Basically, under your acromion, there is your subacromial space, okay, and there's a lining on the top of the rotator cuff tendons, which is called the subacromial bursa. Okay, it's like a sac, and the function of that sac is to reduce friction when the shoulder moves under the acromial arch. Okay, if this gets inflamed, or if the rotator cuff itself gets inflamed, then whenever you move the shoulder in abduction or internal rotation, you can see it gets impinged. It's called external impingement, and they get pain. So if you were to inject a steroid into that white sac, the inflammation will go down, because steroid is a very potent anti-inflammatory, and they get pain relief. Okay, simple thing done in the clinic helps them. All right. The second common thing which I see in my clinic is people come with very stiff, very stiff shoulders. Have a look at this. And yeah.
Elaine, tell me what brings you here to our clinic.
I've had problems with my shoulder for quite a while. Since June last year I had a full banged it, bruising and swelling, it went down, but then all of a sudden I started it was getting irritable. So I went to my GP, he referred me to the physio team. I've been doing exercise in that, but it hasn't got any better, it's got stiffer. I had a cortisone injection, but that hasn't helped. I've had acupuncture, that hasn't helped. So my doctor referred me to you.
Thank you.
So you'll see in a minute how she's really is in a lot of pain, and her movements are really restricted. And you'll have a look now.
Can you take the arm out?
Side.
Yeah. Can you do anything more than that?
No, that push and
No.
pain.
What about taking it forwards?
That's about it.
Okay. Tuck the elbow to the side and move out. Can't do that.
Yeah,
Try and take the arm behind.
right. That's as far as I can get it.
All right. Thank you, Elaine.
So basically, if you ever come across any stiff shoulder with a normal looking x-ray, it's frozen shoulder unless proven otherwise. What's frozen shoulder? It's basically adhesive capsulitis, which is the lining of the shoulder joint. The capsules become very stiff, leathery, inflamed. It gets better on its own, but it can take up to 2 or 3 years. So what we can do is we can go in and release it, okay, through keyhole surgery. So I'll show you a little bit of what I do in theatre with such patients. So have a look at this.
Yeah. Hello Joe, hello everyone. So we are trying to show you what a shoulder arthroscopy looks like. So we are in a theatre with laminar airflow. The patient has been put to sleep by great Dr. Mull here, and we also put a block in, so a needle has been put on the base of the neck. That has blocked the arm, so that helps in pain relief. That's called the IS block. Now this is a typical V chair position. V-chair position, so the patient's face is up here, legs are there. We've got traction on the arm. Okay, I'll put some markings here. If you can show the close-up, Joe. So the front here is the coracoid process. The coracoid process. This is the acromion. This is my anterior portal, my lateral portal, and this will be my posterior portal. Okay. So thank you, Ken. I'll take the knife. Happy to start, Andrea? Yeah. So I'm going to put a mark there. Okay. That's a small portal. Thank you. And I'll take a trocar to go inside the shoulder joint. Okay. That's it. I'm in the shoulder joint. Stay like that. This is the camera. Okay, so I'm in the shoulder joint like you can see in the screen, but it's not clear because there's no fluid inside. I'll put fluid in. So the minute you put the fluid in, you'll start seeing a bit more. So we switch the fluid on, so I'll switch the fluid on here. Okay, so focusing on the screen now, you can see that, can I have a needle please? This is the shoulder joint, okay. Thank you. On your right is the glenoid, the socket. On the left is the humeral head, okay. That's along with the biceps. I'm going to come in from here, from the front here. Okay, there. So I can take these bubbles off. Okay, I'll take these bubbles off. And now, this is along with the biceps. Okay. 1 second. Let's take this needle off. I'll show you pics in a minute. I'm going to make, this is called the anterior portal, the front portal, okay? I'm going to enter here. See, my knife will come, if you can see the screen, my knife will come over there. Take this out. Thank you. This is a trocar just to make it slightly wide. Okay, make sure that we are right in the joint. Then I'll use this instrument here, which is called the magic wand. Okay, so it is Harry Potter's wand. And so now you can see this is the subscapularis muscle. Okay, this is along with the biceps here. This one, that's along with the biceps I'm pushing. Okay, I'll take a picture here for record. This is the glenoid, which looks reasonably good. The humeral head looks reasonably good. You'll go inferiorly here. This is the joint capsule, a bit tight. Okay, this is the back of the cuff. I'll come in the front in a minute. And out the needle again. There's a big mercury bubble here. I want to get rid of this. You can see a little bit of arthritis there, but this is the rotator cuff attachment here. Okay, I'm going to lift this up. That's the rotator cuff attachment there. We'll take a picture. So in this case, the main problem is front. Can you see this? All this is scar tissue. This is stopping the shoulder to move, and this is called the frozen shoulder. And we are going to release this using this instrument. So I'll show you a little bit of release, and then I'll show you another video later on. Okay, so we start releasing it from here. See how this releases. Okay, the process is quite long, so we'll finish it here. Joe, thank you very much.
Okay, so once we release it, then we also do manipulation on table and we achieve full range of movement, and then see the patient back in our clinic in about 6 to 8 weeks. We give them a sling for about a couple of days. The good thing about this is that a lot of this stuff used to be done by open surgery, and we can do it by keyhole. So I'll just show you, look at the scars now.
Yeah. Okay, so we've just completed the procedure. I wanted to show you that, look at the size of the keyhole here. Joe, can you focus? This is the size of keyhole which we used. And there's another one in the front. I don't know how you will come here. Joe, look at that one. Can you see that one? Really, really small, tiny hair. Okay. So yeah. So, and what we'll do is, so we just use the steri strips. So we don't use any staple tape. We don't use any. We just do that. So approximating the edges. Okay. And within about 7 days, this heals up just like a cut. Okay. The same thing we do on the top here. A little sterile dressing goes up here. That's it. We're just going to put a sling now, and the patient will be woken up. All right. Thank you very much. Thank you.
So yeah, then they come back to the clinic, and sadly this patient could not come. She came back, but we couldn't see the video. But something similar we recorded, so you can see the experience of the patient now.
And please, can you tell us what problems did you have with your left shoulder, and how many days post surgery you are, and how do you feel?
Before I had the operation, I couldn't lift my arm up further than here, and I was having loads of pain all across the top, down the back and over the front. After the operation, I think it was about 3 or 4 weeks, and things started feeling a lot less painful. Then on the 6th week, I started off on my physio, and now...
Wow, brilliant. So you're about, what, 8 weeks from surgery?
8 weeks.
And you're very pleased?
Amazing.
You're happy with the services you've had?
Amazing.
Okay, lovely. Thanks very much, Michelle. So Michelle had a subacromial decompression on her left shoulder along with some capsular release, and she has had a very good outcome. Thanks very much, Michelle. Thank you.
So these cases are quite common in the clinic. Other cases which are quite common, which I see every day, is if you can see, I don't know if you can, how nice it looks on your screen, but this is a case of a lady who's about 80 years old, and she's got significant arthritis in her shoulder. And it's very painful. And to be honest, the only thing you can do is you can give them a new shoulder. But this lady also had a problem that she had no functioning rotator cuff. That's why I had to do something which is called a reverse shoulder replacement. Okay, so I'll show you the x-ray. This is a post-op x-ray. So you can see that where on the socket side, there's a ball here, okay? And where the socket should be, where the ball should be, there's a socket. That's why it's called reverse shoulder. The reason why we do a reverse shoulder is because it gives, essentially provides mechanical advantage to the deltoid in absence of rotator cuff, because it changes the center of rotation, okay? So this lady is about 8 weeks, I think, after her reverse shoulder.
Yeah, you can tell us now.
Oh, yeah, I had a total reverse shoulder.
Sorry.
Yeah, you can tell us now.
Oh, yeah, I had a total reverse shoulder replacement 8 weeks ago. I've had some pain, obviously, but it's got, the movement has got better. I can move my arm right up and to the side and just to there.
Okay.
And across.
Overall, do you think you are better than what you were before surgery?
Oh yes, for movement and the pain. I don't get the pain so severely at night, awful nagging pain.
Okay. So for now, it looks like it was worth having the operation.
Yes.
We'll see how it fares in the long term.
Right.
Thank you very much.
Okay, so other type of patients who come to me, you can see, I don't know how many of you can spot what's wrong here. Okay, let's see who can spot what's wrong here. Answer, please. Answers. What's wrong here?
Posterior dislocation?
Did you say posterior dislocation?
Is it anterior?
Well, I won't tell you. Why did you say posterior?
The humerus looks like it's out of its socket, the head of the humerus.
Yeah. Full points for that, Stephen. Well done, because this is definitely a dislocated shoulder. Now, this is an anterior dislocation. Posterior dislocated shoulders, you have the classic light bulb sign. So this is, and you're right, it's impossible to tell on an AP whether it's an anterior or posterior dislocation. But on an AP, if you have a light bulb sign, then that means that's a posterior. So you definitely need an axillary lateral here. We don't have one, but this is just to demonstrate that this is the kind of patients the young patients, they put back in the ED under sedation, and we've got several techniques we can teach you when you come to us how to reduce them back. But some of them actually continue to dislocate, and why is that the case? It's because they damage a structure called the glenoid labrum, which is right in the front of the socket. Okay, let me see if I can show you. So look at that. That's the front of the socket, and the glenoid labrum is being damaged. So when the shoulder comes out, it damages that labrum in the front, and the shoulder keeps popping out. So it's simple operation. What we can do is we can just go in and fix it. So we through keyhole, just like what I showed you before, you go in, this is a socket, and you can see that torn anterior glenoid labrum. This is called technically the Bankart lesion. Okay, so we roughen up the front of the glenoid using special instruments. They're called the burrs. Then we try and use some sutures to tag this glenoid labrum back to where it belongs. Okay, and with time it heals up. So there are several ways of different types of sutures you can use, but this is this is called a knotless anchor. So basically you drill a hole in the front of the socket, and then you take an anchor which is biodegradable, and then you put it down there, okay, and you cut the sutures, and then you put about 3 or 4 of these sutures. And then we hope that, with time, this will provide the same bumper effect which it was providing before the patient had the injury. So this operation is about, I would say, 80% successful. Okay, it all depends on when you catch the patient. If you catch them early, it's more successful. If you catch them late, then it takes time. Okay, so this is anterior stabilization. You might have to do something similar on the posterior aspect of the glenoid, okay, which will be posterior stabilization. In some cases, this does not work, and then we have to do open surgery, which is we have to apply a bone block in the front of the shoulder. Okay, so that's for another day. Right, so then we see, so what would you do here to diagnosis? Who's going to tell me? Come on, someone.
Also, there's just a question in the chat that I'll read out as well.
Yeah. Yes.
It says, how long are your procedures normally?
Oh, well, it can see. It all depends. So, the frozen shoulder release I showed you, that takes me about 25, 30 minutes. A decompression would take me something like 30 minutes. A shoulder replacement will take me about an hour. So the surgical time when I'm actually doing the procedure is usually about an hour or less. Sometimes it can be long. So I'll show you some cases in which it takes slightly longer because if you have to open up quite a lot. The overall time which the patient spends in theater is much longer because they have to have the anesthetic, and after the procedure, they have to be woken up and they have to be taken to their recovery, etc. So does it answer the question?
Yeah, I think so. Thank you.
Okay. So yeah, what do you think we can do with this? This is a broken arm bone, all right? And you can either leave it alone or you can fix it. If you leave it alone, then there's actually, to be honest, you'll be surprised. There's a good chance it might just heal. And But then, you know, you explain this to the patient and say, what do they want? They say, look, I don't want to take a chance. I want this to heal, and I want it to heal in an anatomical position. So you give them an option. I can nail this, I can plate this. And if you're happy to take the risk, I'm happy to do the operation. And this patient said that, yes, I'm happy to take the risk. Please put a nail in. I think we put a nail in like this, okay? So this is also a closed procedure. You don't have to open up the arm. You just go on the top of the shoulder, make a small cut and put the nail in and put the screws in. Something similar. Next patient. This patient said, I want surgery, okay? And instead of using a nail here, you know, we did a plate here because we wanted a better reduction. So we did a plate with some interfract screws. So this is the case which will probably take you about an hour and a half, okay? Because you have to open up from the back, you have to look at the radial nerve, you have to protect the radial nerve, and you have to get the anatomical reduction. You have to get the screws right so that you get nice interfix and the plate. So there's a lot involved in this. Okay, and the positioning of the patient is that they're lying lateral. So you have to make sure that that all takes time.
We have another question, Mr. Garg.
There's another question in the chat. It just says, what is your opinion on non-operative treatment and lupus, L-I-P-U-S?
Yeah. Lupus, you mean to say? Lupus.
Yeah,
L-U-P.
perhaps, maybe.
I don't think it means lupus. I think it's low intensity pulsed ultrasound.
Oh, I see. Okay. Yeah. Good question. Okay. So low intensity pulse ultrasound scan has been very successful, and it has reduced the rates of non-union. Unfortunately, it has not been heavily approved by NICE because the NICE is a regulatory body in UK which approves new treatment. So the way the low intensity ultrasound scan works is basically it goes and it stimulates the bone healing by stimulating the osteoblasts. Okay, and but we don't use it. I use it only for delayed unions or non-unions if the patient does not want surgery. So that's when I use it. Otherwise, we don't use it routinely. Non-operative treatment is, in my opinion, the best form of treatment for most patients, and surgery is my last resort. For example, this patient here, this patient, you can see on the screen, they've got 2 injuries. By the way, Stephen, if you look at the humeral head, this is almost a typical picture of a posterior dislocation, although in this case it wasn't dislocated. This is the light bulb sign. So if this head was slightly more lateral, you would say that this is a light bulb sign. So this guy was in a road traffic accident, motorcycle accident. You can see that the scapula is completely shattered and the clavicle is completely shattered. So this was a floating sort of shoulder. You can see there's no connection of the shoulder with the rest of the body because the clavicle is gone and the scapula is gone, right? So in these cases, fixing clavicle is a good idea. Otherwise, there's higher rate of non-union. So yeah, we ended up fixing this one. So this is the 3D CT, and you can see how bad the fracture was. Okay, so we used a plate to fix that, and that went on to heal. Sometimes you get a fracture, which is, so this is a proximal humerus fracture, and we ended up plating this. This is just a small video to show you how we plate it. Okay, so there's several ways of sort of fixing the proximal humerus fractures, and you can see the fracture lines going through. So you have to, the most important thing is to get the right reduction. This plate application is the easiest bit of the operation. The most difficult bit is getting the reduction right. Okay, so you have to reduce and then you apply the plate and then you fix the plate. This plate has special locking screws. So even if you have an osteoporotic bone, the screws actually lock into the plate and the whole construct becomes quite strong. So even if you have an apple, bone as soft as apple, and if you put the plate in, it'll actually stick into the apple. And if you try and take it out, you'll have to take the whole apple, the big bite out of the apple. And so that's just to give you an example that how strong these screws can be. Having said that, at the end of the day, the pull-out strength of any screw depends on the quality of the bone. Okay, but these are quite successful. These are called Philos plates. Okay, and locking plates. And the advantage of doing this plate is you can leave them out of sling from day one. They usually end up healing in about 3 weeks' time. Okay. Another fracture. Now, this looks quite tricky, doesn't it? It's completely off-ended. So I had to replace this one because we couldn't fix it. Now, where are we in terms of time? We have got only 10 minutes. So now, because after this, I've got a long video of, I did a vlog because my daughter said, Dad, why don't you do a vlog? It might be much better. So I'm so bad at editing. So this vlog is about, I think, 25, 30 minutes. I don't think you have time for that. But I've got, you know, what we can do is we can take some other questions if you have. Let me.
You don't need to rush, Mr. Garg. We can sit through it.
You're sure?
Yeah.
Yeah, for
Okay.
sure. That's fine. That's fine.
It's not a problem.
Okay, I'll leave the voice.
I can't show you much, I think.
Please don't laugh.
But yeah, we'll park up in a minute and then.
One of my days.
So
I'll have a clinic.
Right, I think I got a space. Great. Let's park up here. Right within the white lines, are we? Okay, looks like we are. Right, get the keys out. Okay, kind of stop this for the time being. Right, so that's the car park. It's a farm car park. From the space to strike. So what I was saying was, yes, I have to be a part of the training and mentoring. On top of all this, unfortunately, I'm also currently the clinical lead for trauma and orthopedic service. So that role takes up a lot of my time. So I have to attend a lot of useless meetings, and I have to do a lot of assessments, planning for service delivery, problem solving, and thank you. So yeah, okay, we'll catch up a bit later. This is part of the hospital, so this is the education building, and this is where medical students come for the lectures. Okay, I'll catch you later. So guys, this is my clinic. Okay, so we get given these computers. This is lovely Debbie. She's helping me in the clinic. Thank you, Debbie. So this is how it's done. So Debbie will give me a list in a minute. So thank you, Debbie. So this is a list of patients. So we go through the details, and then I get given pieces of paper, and I go through the medical records. I open up the system here, and then we see the patients here. So each patient is given roughly about 15 minutes. Okay, and we try and help them this way. So I see if any of the patients are happy to get themselves recorded and show you guys, but other than that, this is the clinical setting. Got a lovely skeleton here, you might have seen. Okay, so yeah, he's got a mask because of COVID, and he can't be more dead anyway. But yeah, okay, catch you later. Guys, I'm in my room now, so doing some admin work, so lots of paperwork, and just answering queries from the GPs in the community, and they send us letters regarding whether we need to see the patients in the community or not. So yeah, and after I'll sort them out, I'll give it to my secretary on her desk, and then she will send the letters out to the community and my communication. So yeah, and this is what I'm doing in between the two clinics, and trying to just finish my lunch at the same time. Right, I'm approaching the day surgery. It's Monday morning, so I have 3 cases, so get into this day surgery unit. You have to day surgery ward. So here is Diane Kapoor. She's my first patient for this morning. I think she might be the first, or yeah, she's actually the first on the list. So Diane, you're here for your right hand middle finger.
It's this one here, yeah.
This one. So what's wrong with this?
It locks and once
Locks, yeah.
once it's down, I can't have to physically
Yeah,
open it up.
yeah,
and It's
okay.
quite sore.
And you've tried the conservative treatment, haven't
Yeah,
you?
yeah.
Okay, so do you know what we're doing today?
I think you're just releasing the tendons, aren't you?
Yeah,
I believe?
absolutely, absolutely. So this procedure is under local anesthetic.
Yeah, that's fine.
Okay, so we won't put you to sleep. So
Good.
what we'll do is, we're just going to, I'll just mark this because this is a legal requirement. It's a right middle finger, right?
Yes, it's fine, yeah.
That one.
Yep.
The ring finger. And an arrow there. So essentially what I'm going to do is give you a local anesthetic there and there.
Yeah.
This will numb the entire area. Then I'll make a small cut around there,
Okay.
right?
Yeah.
My hands are not normally as shaky, but I'm just holding the camera here. Okay, so I find the pulley, which is or the ligament, shall we say, which is tight, and I release that. Once I release that, it'll be moving
Lovely.
again. I'll suture it up with something, hopefully, to control infection, watertight,
Okay.
closure, and then I'll give you a tight bandage just to control the bleeding. It's not as tight to squeeze the blood out of it. It's
No,
just
fine.
firm dressing.
Yeah.
Yeah. Now you can take that dressing off in a couple of days. Today is what, Monday?
Monday, yeah.
So you can take it off on a Wednesday, and just use your hand as normal. Just make sure you don't get water to it. Make sure you don't get it dirty, otherwise,
Okay.
you
Yeah,
can
yeah.
get infection in. The procedure, it is usually risk-free. Okay, but obviously, if I make the cut in a wrong way, if I damage your tendon, if I can damage your nerve, I can damage a vessel, and so if that happens, that is not good.
No.
I need to I need to repair that on the table. Okay.
Yep.
I haven't done that damage yet
Good.
so far in my career, so I don't want you with my
Oh,
first
no,
one.
thank you.
The complications which I have seen in my in these operations is infection. So because this is a soft tissue procedure, we're not putting any implant in. We generally do not use any antibiotics.
Okay.
But because the theatre is very clean, infection rate is like 1 in 100. Okay, so if you're one of those unlucky ones,
Okay.
even if you get infection, most people get better with antibiotics.
Yeah.
In some cases, you have to take them back to theatre and wash it out. Okay. But
Okay.
overall outcome is usually good.
Good.
Okay.
Yeah.
What sort of work do you do?
I work across the road at the high school. I'm a teaching assistant.
You're a teaching
So
assistant.
can I
okay.
go back tomorrow?
So right, yes and no. So I mean, what are you supposed to do? So if your right hand is bandaged, can you still work?
Yes, I can get verbal instructions, but the thing is,
Okay.
we're testing the children over there for
Okay.
COVID
All right,
at
okay.
the moment, so I can still help in the process of that.
All
if
right.
That's okay.
Okay. Yeah, that's fine. I think you can just be careful about
Yeah.
the hand. Okay.
Yeah.
So maybe you can keep the bandage in for longer then, up till the weekend,
Okay.
so that you remain protected when you go to school.
Okay. Yeah.
All right.
Lovely. Yeah.
Okay, fantastic. So yeah, and you'll have some stitches. I'll see how the edges are. If the edges are posing well, I'll just put the internal stitches so that they don't have to come out.
Okay. Lovely.
But if the edges are not opposing very well, I'll just put some interrupted sutures so that they can come out in 2 weeks' time.
Okay.
The scar is slightly better if I put interrupted sutures, but the problem, the trade-off is that you have to get them removed at the GP
Okay.
surgery. Okay.
Okay. Yeah.
Do you have any preference?
No. Whatever.
Okay.
You're the professional.
Fantastic. So, any questions?
No. That's all
No?
good.
All right. Well, thank you very much. Thanks for letting me
That's
video
okay.
this. Okay. So let's hope that the medical students get some information out of this.
Okay. Lovely. Yeah.
Okay, thanks very much. So, Mr. Lonergan. Yes. Hi, sir. How are you? My name is Sunil Garg. I'm an orthopedic surgeon, and I'm your surgeon this morning.
Okay.
Right. So let's have a look what we're doing today. Okay. So let's have a closer look here. Kinina, you can come from this side if you want, or you can see it. So this condition. Do you know what this condition is called, sir?
Oh yeah, we can't pronounce it actually, but I have been told, yeah.
It's by a French surgeon. It's called Dupuytren's contracture.
Yeah.
So, lovely. You find a consent form. So, right, let's have a look. So, you got to mark this. So it's your left ring and the little finger. Okay.
Well, it's more this one as well. So because that finger's bent. Can you
That's
see
going.
that? I can't wear my wedding ring on this finger because that's sort of.
Right. Okay.
I don't know. I mean, you can see that's sort of bent to the side, isn't it?
Hmm. This looks like a big job. So
Oh,
let me
dear.
put a mark here because. So what we were told was that you had just
one side, but it's got 3 fingers. That means it extends the procedure by about half an hour.
Yeah, I did. When I come, I did point it all out to the chap
Okay.
who.
So what we do is if it's 3 fingers, it becomes very tricky because normally you make a zigzag incision which covers 2 fingers. If it's 3 fingers, you have to give a separate incision. The chances of complication go up with the second incision.
Yeah.
But we can still manage.
Yeah, that's fine.
So we will aim to correct this finger and this finger and this finger as far as possible.
Yeah,
It might
yeah.
not be totally.
No, that's fine.
Okay, can you make a fist for me and straighten it? And can you feel me touch you there?
Yeah.
Feel me touch you there?
Yeah.
Okay, so no
Yeah.
problem.
No.
So after the operation, you might have a little bit of difficulty in feeling the
Yeah,
tips.
I did read that.
Yeah, in case we nick the
Yeah,
nerve,
yeah,
but
that's
hopefully
fine.
not.
No.
The hand is terribly stiff after the operation for a few weeks.
Yeah.
Okay, so you'll have to do a lot of hand physiotherapy to get it going.
Yeah.
It takes best part of sort of, a couple of 2 to 3 months to
Oh,
get the
right.
hand
Oh,
working
right.
very well.
Yeah.
You're in a splint for about 4 to 6 weeks. Okay.
Okay.
Are you right-handed?
Yeah.
Okay.
Yeah.
So you can
'Cause
manage.
You got to do that. You're
Oh,
gonna-
you got this, the same on this side as well.
Yeah, but obviously.
Oh, right. Okay.
I'm going to have this one done, and then obviously.
Right. We could have done this one for you today.
Sorry.
We could have done this one for you today if you're right-handed.
Oh, I didn't know which one to say really.
Yeah. Which one does it say on the list?
I told him this one. I did tell
Yeah,
him
it
the
says
left.
left on this one.
Yeah.
Yeah. You want to continue on the left one?
Yeah, it didn't
Yeah.
make any difference. I didn't know what to say really, to be honest with you.
Now I'm just thinking that if you're right-handed, and I mean it's entirely up to you. I can do this one. You want this one done first?
Got to have one done, haven't I?
Grina, what do you think? This one?
So I think he can start the first try with the left one.
Okay.
Because it's his first surgery.
Uh-huh.
It's a
And
big
then,
lump there on that one.
yeah.
That's
Yeah.
a big lump there.
Yeah, big lump there. Yeah.
Yeah.
We'll try and get rid of this lump. Okay.
Yeah.
So yeah, you're otherwise fit and well.
Yeah, yeah.
How old are you?
Sorry?
How old are you?
70.
70.
Yeah.
No medical conditions? Any
No.
heart conditions?
No.
Okay, very good. You will be seen by an anaesthetist anyway. Okay,
Okay.
very good, excellent. It's a safe procedure.
Yeah.
Okay, it's a safe procedure. The anesthetic is safe. The procedure will take me about an hour or so.
Yeah, that's
Okay.
fine.
And then you'll go home today in a bandage.
Yeah.
And you'll come back and see us in a week's time.
All right.
So that we can see how the wound looks like. Okay.
Yeah.
And in a couple of weeks' time, we'll take the sutures out. Okay. And as I said, you'll be wearing a splint. You'll be slightly handicapped at home because
Yes.
you'll be using your right hand mainly.
Yeah.
Got someone to look after you at home?
Yeah.
Okay,
Yeah.
fantastic. Fantastic. Do you have any questions about this procedure at all? No?
No.
Okay,
No.
fantastic. And
The least I know, the better, I think.
and once again, thanks for letting us
No,
take
that's
take
fine.
this video
Yeah.
for the
Yeah,
medical
no, it's
students
fine.
here. Very
Yeah.
grateful. Thanks ever so
Yeah,
much.
So when I had this one done, do they automatically contact me?
No, so that's the thing. Because of the way system is, I think you'll have to ask your GP to refer you to us
All right.
for this one. But we can always do that. We can always ask your GP to do that. I can write to your GP. That's
Would
not a
you?
problem.
Because I did, when I come up, they did say I've got to have both done, and then
Right.
but they said do the left first.
Okay.
But I didn't know what the
All right.
system worked.
Okay.
so-
If the referral has been for both of them anyway, then we can just add you to the waiting list when you come and see us next. Just remind us of that. And
Okay.
we'll do that. Okay.
Okay. Yeah.
Thank you very
Yeah,
much.
Thanks very
Cheers,
much.
Thanks. How are you doing? I'm Sunil Garg.
And thank you very
yes.
much for getting me in so
No,
quick.
that's all right. Absolutely. So, we're doing your left shoulder, is that right?
That's correct.
And how's the left shoulder? It's been very painful?
Very well. I
Yeah.
mean, the pain I've got now is bearable, but when I move it, do things with it, then that's when I get the pain coming down the shoulder.
Hmm.
You know.
If you want to stand up for me, just let me tie you there in the back so that you don't get undressed when you. So right. Okay, that's all good. Now lift this arm up for me if you can. Go up. Can't go more than that. Okay, can you go in the back? It's got a lot of restriction range of movement. Do that for me. And rotate out. So please sit down. There is a lot of damage inside your shoulder. And you know, we had an MRI scan that confirms damage to all the tendons in the shoulder. So the plan is I go inside your shoulder today and I have a look what's damaged, what's not damaged. What can I do to repair it? I will obviously try my best to repair everything possible in one go. The recovery is going to take several months. Okay, so you'll be off work for quite a lot because you're a delivery driver, aren't you, for Esther?
But if you can't fix it, then they'll get rid of me.
Okay.
Yeah.
So have you been back to work since?
No.
No? Okay. So you've been off work for how many months now?
3.
3 months. Okay. All right. So I think you'll be off work for another 3 to 6 months. It looks like.
Yeah.
So and after that, we'll see what we find inside the shoulder. How good we can fix it and how much physiotherapy. Because usually in cases where you have all the tendons ruptured, the recovery takes much longer. Okay. And because you have to give it time to heal, you can't move it, which means that the stiffness comes in, which is an added problem. So you're trying to fix one problem and then you get the second problem. So let's see how it goes. Okay, you know that there's a risk that we may not be able to repair it. There's a risk that I might have to open it. Then
I mean, I've tried just going across.
Paperwork. Do introductions first. So I'm Sunil Garg, surgeon today. Yeah. Clear.
Ian Jenkins, ODP.
Rennie staff nurse.
Joe, staff nurse. Study consultant.
Thank you very much. So we've got 3 cases, guys. First.
This is the team brief we have to do, which is called the WHO checklist. Before we do every list, so we discuss what cases we have, what equipment we need. I mean, this information is already sent to the theatre already. This team is aware. We double check, and if you do a WHO checklist, the chances of error goes down significantly. Okay.
So this is a changing the room. I just changed into the day surgery equipment. Really starting LP and porter and everything. So fantastic. So these are theatre lights. The air under that is, this is a day surgery theatre. Every theatre is different. Okay. So here, the digital nerve here. Okay. So what I've got here is local anesthetic xylocaine. Push. You okay there, Diane?
Yeah, fine.
Very good. Thank you. Very, very slow and gentle push.
So I'm using xylocaine with adrenaline.
And I'm going to now direct the needle this way.
So it hurts.
Inject. And I advance. So I'm getting ready for scrubbing. The team is getting ready. So we've got a disposable gown. And these are reveal gloves. They come in different sizes. So they're double gloves. Okay. So double gloves. Through that. So let's see what we do with the scrubbing. So you just wet your hands first, and you get a scrubber because that's your first scrub of the day. And
So you've already been back at work,
you've got either you can use betadine here. Okay. Very much. We'll do this now. Thank you, Rennie. Step around. Right. Are we ready to rock and roll?
This is when I'm releasing the tendon for that patient you saw earlier. But that's one. A1 fully being released. Okay.
Okay. Let's have the sutures now.
Oh, you want to shoot tendon again?
Sorry?
You want to shoot tendon again and zoom?
Yeah. Sure. So take it out. Yeah.
My registrar wants me to show you guys the tendon so that I can show that it's completely released. So this is the tendon.
So there are 2 tendons, flexor digitorum profundus and superficialis. Superficialis on the top, profundus is on the deep. Okay. You can see a little bit of roughening here of the tendon. That's the wear and tear. Thank you, Remy.
Profundus means,
but other than that, it looks quite nice and healthy.
Always means deep.
Okay.
That's why profundus.
So we could potentially do an inside suture, but if we did interrupt it, the scar is a lot better. So we'll do an interrupted suture. So a simple interrupted suture like that. This 4. although it's a very small, short procedure, there's still a little bit of bleeding because the palm is quite vascular. Okay, so that's why it feels like that. Otherwise, it looks very good. Do you want to have a look at it? Yeah, we're done. Thank you very much. So it's not yet done, so we have to make sure that we record the procedure, upload, and then send it to the GP. Okay, so I'll do a fracture tape of the special.
Anyway, so then there's a fracture case I was doing, but you know we're much out of time. So right, so basically secrets of success, which I can tell you from my last 20 years, is that you have to do it for love. You have to do it for your passion. I really do enjoy going to work every day. I absolutely love spending time with my patients, trying to help them as much as I can. And my reward is just one thank you that my hand works, my elbow works, or my shoulder works. And that is, and that is really, and you got to push yourself physically and mentally, because you see a lot of sickness in the hospital. And you start self-doubting yourselves if you don't get good results, but you know, you just have to persevere and help and serve. So the idea of being a surgeon is that persist crap, okay? So keep away from criticism, rejection, assholes and pressures. Just, they are part of your life, all right? So final thoughts is do what you think is best for you. Do not leave someone else's life. Your time is limited on this earth, so do the best you can. Okay, others' opinion matter, but your opinion is final, and that's going to help you in your life. Okay, just follow your heart. And what the Apple chair said, stay hungry, stay foolish. Okay, thank you very much. I'll stop sharing now.
Thank you so much. That was really, really good. I already had a lot of messages from people saying they were really happy they came and it was awesome. So okay, I think everyone really enjoyed the vlog as well.
Oh, well, it was my first attempt. I've never done a vlog before. I'm so sorry. First of all, I got told off that I was doing it in the portrait mode. I should have done it landscape. So
we couldn't tell. It looked professional to us.
My daughter will help me. Yeah, any questions? I'm quite happy to be here.
Yeah, I think there's one question in the chat, which is, there's a lot of messages saying this is brilliant, thank you so much, amazing to see. And one question which says, when and how did you realize you wanted to become an orthopedic surgeon?
Okay, if I'm going to tell you the honest answer, okay, there's a long story, but I'll make it short. So I never wanted to be a doctor. Okay, I wanted to be an engineer, and because I wanted to escape taking the local language, Hindi, in where I was growing up, I took a biology. And because I took a biology, my parents made me write the pre-medical entrance test. And I was very lucky I passed that test as well, and I passed my engineering test. But I wanted to go to the Cambridge of India, which is called the IIT, for my engineering, and I failed that exam. So I was not in a very good way at the time. This is going back in 1989. And so my parents said, oh, why don't you become a doctor like your sister? And I said, okay. They said, you know, you'll be serving the community. It's a very good job, blah, blah, blah. And I said, okay. And I used to like the way body works anyway. You know, so I said, okay, let's do it. Then when I was into the medical school, I didn't like the ECGs and all these complex chest x-rays, and I said, gosh, I got myself into big trouble. Then I saw orthopedic surgeons. I said, these guys are nice. They're like carpenters. And then guess what? All the richest doctors in the city were all orthopedic surgeons. I said, this has got to be for me. So it was the sense of thinking that I'm going to be doing some carpentry and rather than heavy medical work. And that got me into orthopedics, and I still do carpentry. And, you know, yeah, so that's the answer.
Okay, great. I think that's a great answer. The next, wait, Stephen, do you have a question as well?
Yeah, we have two more. I think you missed one earlier on.
So there's one which says, how important do you consider the physiotherapist in your work?
Oh my God. Physiotherapists are they're my wives at work. Okay, can't, just like you run your house with your partner, you run your orthopedic service with your physiotherapist. You as a surgeon are absolutely zero and nothing without your physiotherapist. You know, it is absolutely the most important. So, for example, I showed you that case of hand, you know, where I was releasing the tendons and I was releasing the tibialis contracture. If I was to leave that guy alone, you know, he will be stiff again. So you need a hand therapist or a physiotherapist to tell him that, look, you got to move it and the way and encourage them. So in short, physiotherapy makes a huge amount of difference. Okay, I know that there are papers around there for certain conditions where whether you offer them physiotherapy or not makes no difference. But in a lot of conditions, especially hand surgery and complicated shoulder surgery, physiotherapy makes huge difference. And I would say the same for hip replacement, knee replacement, and spine surgery as well.
Okay, great. Are there any more questions, Stephen?
Yeah, there's one. So, Mr. Garg, the next question is, could you possibly mention the pros and cons of working in the NHS for someone who would consider working in the NHS?
So is it working in the UK or working in UK and working in the NHS?
Specifically working for the NHS.
For the NHS, okay. So the thing is, if you are in UK, you could either work for the NHS or you could work for just the independent sector, or you could work for both. If you think that you can get enough business in the independent sector, then you can work in the independent sector. The advantages are that you are your own boss and you can do whatever you like at whatever time you want. You can go on leave whenever you want, etc., etc. The benefits of working in NHS are much more, I think. Number one, I think NHS gives you a lovely platform, a fantastic team to work with. So you feel that you're actually sharing the responsibility. So if I'm doing any surgery, as a surgeon, you will have a lot of pressure felt on you. Okay, what if the results are not good? What if my patient dies? What if they lose their hand? So what you have to do as a surgeon is look after your surgical skills very well. Okay. And then the team, if your team building is good, they will take care of the rest. Okay. Have you guys seen the video of Captain Sully's landing on the New York airport? Yeah, in Houston, in Hudson River. That is, I really recommend that you should see that video because that will teach you about the human factors. The NHS gives you very good work-life balance. Okay, if you compare NHS with working in America, working in anywhere in Germany, France, in Middle East, the work-life balance you get in NHS is huge. It's very good. It's the best probably because you get time to train, you get time to teach, you get time to do the clinical work, plus you get some time off, you get very good annual leaves, you get very good study leaves. Okay, and the only thing is maybe you could say, well, my counterparts earn a bit more than I do in America, but then that's a decision you want to make. What you want in life is money, just money, or a bit of everything. And I choose to get a bit of everything, so I get a bit of everything. So I would say huge advantage of working in the NHS as a surgeon, plenty of support, very good all-rounded practice, very satisfying actually. The only thing which frustrates you is the resources are limited in NHS. So people wait for ages for the treatment. It's because we have less hospitals, less doctors, and I hope one day that will not be the case.
Would you say orthopedic surgeons have the best work-life balance out of the surgical specialties?
Well, I don't think so, Stephen, because see, when I'm on call, okay, I do 1 in 9 on call. Every 9th day I'm on call, but that's just to make you understand. Otherwise, I do a week off on call. It is quite hectic. Can be quite hectic. The urologists, the neurosurgeons, the cardiothoracic surgeons, the general surgeons. I think it is different for everyone, but I don't know, work-life balance for maybe ophthalmology surgeons is slightly better because they do not have on-calls. Even if they have on-calls, they do not get the intensity of cases which we get, like opened up pelvises, open fractures, limb ischemia, etc. So many things. So ophthalmology is a branch where I think you will find that the work-life balance is slightly better than others.
Thank you for that. We have two more questions. So for someone who's interested in surgery and is obviously thinking of becoming involved in research, would you say at our age, as undergraduates, it's good to just have any type of research, or would you say to start having kind of specialist interest and kind of fine-tuning your interests and doing research and quality improvement projects and case studies in that field, or do you think a general or general interests are okay to get involved into
Sure.
specialty training?
So to answer that question, we have to understand why is research important, okay, for doctors, surgeons. So the reason the research is important is that we have to develop ourselves, our brains, so that we understand evidence-based medicine, okay? And when you do any research, whether it's a small audit, quality improvement project, you understand the process, okay? You understand the process, you start reading papers, you start understanding how to critique a paper. So even if you do a study on the relationship of lockdown on sale of McDonald's burgers, that's good enough. Okay, you don't have to do a study in orthopedics. You don't have to do a randomized controlled trial. You don't have to do a meta-analysis. What people are looking for in interviews in your portfolio is evidence of some interest of research, whether it's done in orthopedics or any branch. You could be studying COVID, you could be studying anything, but that shows that you have that mental aptitude of a researcher, of someone who scrutinizes things, who can critique the research, the methodology, and understand whether this evidence is crap, or this evidence is good. Okay, so that's the whole point.
So basically, the fundamentals.
Absolutely, yes.
Okay. And Alka, would you like to ask Mr. Garg the final question?
I think there's just two more questions. So there's one which says, would a physiotherapy degree be impressive for an interview trying to get into orthopedic surgery? And what else do you think would benefit to help trying to get into ortho?
Okay, so, I can see that as a Jean-Carl Ezoparadi, he has asked that question, isn't it? So, you can contact me directly. I don't mind. Okay, I will just I'll actually type my email address for everyone here. sunil@gmail.com. So they can contact me and I can answer your specific questions. But basically, getting into orthopedics in UK, I mean, as a physiotherapist, you'll have to become a doctor first. And once you become the doctor, you have to go through the same rigmarole of what others have to do. So foundation year, core training. Your physiotherapy degree will definitely help you understand better. You'll be a mature medical student, so that has advantages and disadvantages. But I think as such, when you come to the interview, you will probably have one extra point if you have done physiotherapy as a career before. So because we'll know that, and then yes, you're committed, you understand the way body works, the way the joints work, etc. But it's not something which is desirable that yes, let's do a physiotherapy degree and then come to orthopedics. So it is doable, but it's a rather long route. But if you get in touch with me, with your specific sort of requirements, Jean-Carl, I'll try and help you. How many papers did you publish before applying to orthopedics?
You can read the questions yourself now. That's great.
So I think I had about, so it has to be peer-reviewed papers and non-peer-reviewed papers. So I must have published, I think, maybe about 6, 7 papers. And, but that was along the line. And a lot of them were sort of, and I did a lot of other audits and projects. So I have to say I've never been a very sort of, a keen researcher. So I've been involved in a few national randomized controlled trials now after I've become a consultant. So I've got a few more publications, but I've never been a great researcher, to be honest. So, and one thing I've learned in research and publication is take one job at a time. Do not take too many. I used to take too many projects. Then I used to just sit on them, sulk, and then nothing used to happen. So all my trainees, when they come to me, I tell them, okay, aim finishing one project every 6 months. Okay. And then you will see that you have 10 finished projects in 5 to 6 years. Just pick one and just say, no, no, no. I'm just doing one project, do it, and that's it.
There's also just one more question from Ashwin, which says, what aspect of orthopedics do you dislike, if there are any?
Right. It is, if I'm honest, there's just one aspect of orthopedics which does not sit very well with me, is the recovery time. I had my eyes operated some few years ago, and I saw that results do not take 3 months, a year. If I did any shoulder operation today, if I fixed any shoulder any shoulder case, whether it's a fracture, whether it's a rotator cuff, soft tissue, it's going to take 12 months to recover. A shoulder replacement, even, that takes about 3 months to recover. It's a recovery time, and the unpredictability of the outcome is what is, and sometimes things are out of your hand. For example, infection, you do everything, yet the results get affected, and that pulls you down. I've had several sleepless nights when I've had a bad outcome, and I'm just beating myself that, why did this happen? So there will be these things which otherwise I think, I love orthopedics. The only thing is, if I was to do things all over again, I might think between ophthalmology and orthopedics. Probably will still choose orthopedics.
Okay, great. I think that's, I actually have one more question, but I'm not sure. Will VK is Virat Kohli, apparently, is it? Will VK get a century tomorrow? What do you think?
Well, I hope so. Virat's been doing all right in his 60s and 70s, I think. So I think it all depends. If he opens up, then there's a chance, but he could get a ton tomorrow. Let's hope so. But Johnny Bairstow and Ben Stokes are back in form, so yeah, it'll be a good game tomorrow. I'm looking forward to it. Yeah, let's hope that VK gets a ton. Thanks for whoever said that.
That was from Dylan, but yeah, thank you.
All right.
Let's hope Ben Stokes doesn't get too many.
No, yeah, absolutely, yes. It's the same ground, isn't it? It's Pune again tomorrow, isn't it? Yeah. All the three being played there. Yeah. So, well, thank you again for giving this opportunity. I absolutely loved coming to this forum, and thank you for all the questions and everything. And you guys are doing a great thing, actually.
Thank you so much. I actually had a lot of messages throughout the talk saying that it was really, really good. So I think everyone really enjoyed it. Thank you so much for your time, honestly.
Pleasure. Yeah, if you ever need me again, just let me know. And if you have a special topic or whatever, in orthopedics, I'll be very, very much happy to come and, do a talk for you guys again. All right.
Okay, great. Thank you so much. Also, if everyone could just stay on the call quickly, I have a few of our coming up events to share. Just if you
okay, I'll leave now. Yeah. Okay. Thanks a lot.
Yeah, that's fine. Thank you so much.
Unless you'd like to stay for the FIFA. No. I think you get to share your screen.
Okay, yeah, I just have our upcoming events. So the main one is FIFA, which the registration closes for, I think, next Wednesday, March 31st. It's only 60 crowns to apply, and the first prize is 500 crowns and the second prize is 300 crowns, which I think is a pretty good return investment if you ask me. So I think you need a PS4 to play. So please sign up if you have a PS4. I promise it will be a good time. We also have an online street dance workshop coming up on next Saturday, which also will be very good. And then all our other events will be available on our social media, so you can check that out. Yeah, thank you. You can fill out the feedback form. We'll put it on the Facebook event as well, or you can use our QR code. But yeah, that's it. Thank you so much for coming, everyone. I hope you enjoyed the lecture.
Thank you.
Okay. Bye. Thank you.
Thank you. Bye.